Good evening, everyone, and good afternoon to Dr. Hockmeyer joining us from Vienna. I'm Dr. Shreyas Deshmukh, and it's my pleasure and privilege to welcome you all on behalf of Merck to this focused scientific session on non-small cell lung cancer with specific highlights, a specific focus on MET-X14 skipping and MET amplification. So these mutations, as we all know, play a critical role in non-small cell lung cancer, and they give us, or they represent, a very unique opportunity for precision medicine. So this evening, for this focused scientific sessions, we have an expert faculty, distinguished panel of experts with us. We will begin today's agenda with our chairperson's address. Without further ado, I would like to welcome Dr. Neeti Raizada, ma'am. So madam is a senior director uh, at the Fortis Hospitals. She's the Senior Director of Medical Oncology and Hemato-Oncology at the Fortis Group of Hospitals. Ma'am, I welcome you to this scientific forum. I would request you to please take the proceedings ahead with your session, the chairperson's address. Over to you, ma'am.
Thanks so much, Dr. Shreyas. Firstly, a very warm welcome to all of you. A very good evening and a good afternoon to Professor Maximilian, who is, it's an honor to have him today to speak for us. Can you stop sharing? So I'll share my slides.
I have stopped sharing, ma'am.
We have a very esteemed panel, as you mentioned today, and we all will be discussing about MET amplification and MET14 skipping mutation today. I'll just do a brief overview of rare mutations and its presentation in our country. Well, we know that the most common lung cancer is NSCLC, about 80 to 85%, and adenocarcinoma being the most common histology. Well, when we look at the global incidence, as per Globocan 2022, almost 2.5 million cases were diagnosed in the last census what we had, with a very lethal cancer of about 1.8 million deaths across the globe. In India also, we have similar dismal numbers, with new cases about 82,000 diagnosed each year, about 75,000 dying of this disease each year. India is the fourth largest contributor globally for lung cancer incidence, which is following China, US, and Japan. Lung cancer happens to be 8.5% of all cancers in males and 3.2% of all cancers amongst women in our country. Now, this is a very interesting representation of the ICMR data, which is our national data, in which disability adjusted life years, which was tested in 2004 and subsequently 20 years later, in which initially in 2004, the DALY per 100,000 was cervix, breast, and oral cavity, and lung being the 10th in the list. And now, as per ICMR 2021 data, lung has become the first in the list with 116 plus 100,000 disability adjusted life year. So a very large number. And when we look at oncogenic drivers, we look at oncogenic drivers in adeno and squamous cell as well. And there is a lot of difference between how it is represented globally and in South Asia, especially India. KRAS EGFR being the most common driver mutations across the globe. And then, of course, ALK, ROS, and now we talk about MET, RET, KRAS, BRAF, etc. When we look at small cell lung cancer, FGFR1 seems to be 20%, followed by PIK3, which is about 12%, and then PTEN, which is about 10%. So 60% of adenocarcinomas will have an oncogenic driver. But when we talk about squamous cell carcinoma, almost 50 to 80% will have some driver. They may sometimes not be actionable, but they have driver mutations. As per the testing scenario in our country, well, this is an ongoing debate whether we should do sequential testing or upfront NGS. And a study which was published in Annals of Oncology suggested that if we do upfront NGS, actually there's an additional 1.2% of patients which have actionable alteration. Not just that, we detect complex EGFR in an additional 5% cases, variant in ALK mutation in about 1.5%, and ROS fusions as well in about 3.4% cases. Now, as per the Indian research labs which we use, the TATs, the turnaround time for NGS, is a median of 14.2 days. certain labs offering even earlier or shorter TATs. The cost increment is about 19%, which is significant. But when we look at the overall scheme of things, the cost comes down because TKI are oral medication and cuts the hospitalization cost. Now, when we talk about MET exon 14 skipping mutation and KRAS mutation, in squamous cell histology, an additional 2.4% are noted as additional to what was already existing as MET exon 14, an additional 4.7% of KRAS G12C, which is again an actionable mutation. Well, this is a study in which I was also a part of, in which maybe the selection, maybe it is non-random. There were about 120 patients, and in which plasma-based NGS was done for NSCLC patient by circulating tumor DNA. 29% had EGFR, BB2, which was interesting, almost 10% of cases had, which included SNVs and insertions and duplications. KRAS was seen in about 3.6%, MET in about 5%, which is a larger number than reported, ALK in about 1.8%, and RET in about 2.7%. Now, what is the Indian data, real-world data of MET exon 14 skipping mutation treatment? So this was the study design in which one of our moderators, Ullas, was the main author, in which this was the real-world experience of MET inhibitors and MET exon 14 skipping mutations. This is the largest Indian data which we have. It was a non-interventional, retrospective, multi-center data of about 50 patients. TKI was given in the first-line setting in about 14 patients, and chemotherapy was given in the first-line setting in about 28 patients. All were histologically proven stage 4 NSCLC, who were more than 18 years of age and confirmed MET exon 14 alteration, and all treated with TKI in some line, by the first line, second line, and some of them also in third line. PFS was the noted primary endpoint, and adverse events also noted. Now, when we gave it in the first line setting, the PFS was almost double as compared to chemotherapy, 5.6 versus 11.9. In the second line setting, chemotherapy had 4.6 months of PFS, which was 7.7 months in the second line setting. So this data actually showed doubling of PFS in the first line setting. MET TKIs had higher systemic and, of course, intracranial efficacy, as we all know, with manageable side effect profile. A presence of TP53 co-mutation possibly was an adverse factor noted in this study. There were no new safety signals. And the most common safety signal, most common AE, as we again know, is fluid retention, which could be peripheral edema, GI side effects like nausea, vomiting, and a slight elevation of creatinine. Most of the toxicity was grade 1, grade 2, and were reversible with dose adjustment. So in summary, India is the fourth largest contributor of lung cancer incidence globally. And of course, because of the lethality, quite a few patients die of their disease. Molecular testing assists in selecting targeted therapy, and both modalities, tissue and liquid, have their relevance. MET TKIs, tepotinib and capmatinib, have changed the scenario. And we have data in Indian subpopulation as well regarding the same. So with this, I will hand over the session to our international speaker today. I'll introduce him. This will be followed by two moderations by Dr. Ashish Singh and Dr. Ullas Batra. So Professor Dr. Maximilian Johannes Hochmeier is the head of respiratory oncology unit at Clinic Floridsdorf at Vienna, Austria. He has been a principal investigator and co-investigator in several global phase 3 trials. Actually, most of the important drugs used in oncology, pulmonary oncology settings right now, he has been a lead investigator in Keynote trials and Empower trial, and of course, all other TKI trials as well. And we have the honor of having him today. So over to you, Professor.
Thank you very much for your kind words. And your German is excellent. Normally, I get really strange names, or I get normally some strange wordings, but you could work immediately here in Austria. So thank you very much for your kind introduction. You opened the space already perfectly and showed your Indian data that is really interesting. And we can talk about these data also. We didn't collect this patient population in our center, but I can share with you some personal insights in this setting. Generally, you showed the Indian data about the incidence. What I found and what I thought is extremely motivating is here the data from America for lung cancer. You see the incidence of lung cancer based on the better smoking cessation is going absolutely down. In Austria, we have a clear increase. We had nearly 10% more in the last 10 years or 20% more in the last 10 years. And we don't see that it's going down because our laws for smoking are still extremely liberal. But when you look at this data, when you are more strict, lung cancer is going down here for men and also for women. In women, we still have an increasement, at least in men, we are stable. And what is also happy with the good improvement of our treatments, with our better understanding of the cancers, you see here a clear, on the left side, the man, here the female patients, that it's going clearly down, that also the number of deaths are going heavily down when you follow good therapies and when we try to let the smoking abilities going down. So this is really, when I saw this data recently, I was really amazed by that. Also, the smoking cessation helps. When you have a drug for lung cancer, this is improving 1.3 years of overall survival. You would say, give it to me. This is the best drug I would love to have. And here we see an improvement of 0.3 years when we just stop smoking. So still, even the patient has a diagnosis and you tell the patient, please stop, it still helps. I know a lot of us are sometimes demotivated to motivate our patients in this situation, but this is still a good opportunity to improve the outcome. Also, we have a registry in our center. We have about 800 new diagnosed patients in our center per year. And we have 1,760 patients included in this registry. And you see the majority of our patients are still in advanced stages. Screening is not really established in the moment. We hope we get it, but the majority is still these patients with local advanced or heavily advanced disease. The ECOG status at the time of the diagnosis, we have some patients that are in a very low situations, but the majority are still fit. These patients, for sure, that are fit enough get also the diagnosis. When I started as a young fellow to treat lung cancer, everybody said, Max, treat these patients. It's so senseless. We have so few treatment options, and it was extremely simple. So as a young fellow, 30 years ago, I treated all patients similarly with chemotherapy. Nowadays, we know when we test these patients, our patients, and we treat them correctly, these patients are in stage 4 not surviving the disease, but the overall survival is clearly getting better. So testing is the most important factor to improve the outcome of our patients. And it's not that when a patient has a target that is just there, the patients are not living longer because they have a MET14 skipping mutation or an EGFR mutation. Only when we treat these patients, then the patient is living longer. So MET14 skipping mutation has actually a poor prognosis, but when we treat the patient, then the prognosis is getting better. What should we test? And this is from a recent publication in the Lancet Health Europe. And you see here on the left side, these are the markers we have to test. These are emerging biomarkers that we can test, and we should test our patients with large panel NGS. So we should not just say single gene testing for MET, for example. It's always important that we do large panel NGS, and it got much cheaper. Sometimes PCR testing is still established in some countries, but this is not, here we are still missing patients, and also for more MET14 skipping mutation. Should we also test squamous cell carcinoma? And here is just MET, but generally also in squamous you can find EGFR, ALK, ROS1, BRAF. So we are testing also squamous cell carcinoma patients in our center. From my feeling and from my registry, the population with mutations is clearly lower than in squamous in comparison to non-squamous, but there can be a mutation, so it's clearly recommended to do testing here, especially MET. I always see patients with squamous MET14 skipping mutation, also EGFR. Austria is a very good country in terms of preparing medicine. We have very liberal smoking rules, but we are very good in repairing. So when a patient has the first contact in our center to the biopsy, to the histological report, including NGS, is relatively fast. So we can already after 15, 16 working day, 15 days, we can start the treatment for our patient based on the histological report and all these things. Here's the tumor histology that we find: small cell lung cancer about 13%, but adenocarcinoma in our country is for sure the biggest group in this situation. Patients with adeno, patients with squamous, and also patients with NOS or large cell carcinoma are getting tested automatically. Here's the PD-L1 staining. A lot of patients are still negative. PD-L1 staining high are also here described. What we don't know and what we sometimes, and we need data for that, are patients with druggable mutation and high PD-L1 staining the same patient population. My feeling, and a lot of the data are looking also in this direction, is when patients with a druggable target and high PD-L1 staining, the outcome of these patients is clearly worse. So it makes sense to know that the PD-L1 staining is there, but we should not treat these patients with the immunotherapy like we know it in the wild type patients. Also in MET14 skipping mutations, I always recommend to use here tepotinib as the best drug in this indication, and not treating these patients with immunotherapy or immunotherapy plus chemotherapy, because the remission is clearly lower. I will show you some data later about this topic. Here is the distribution of different mutations. You see in our center, where we have a testing rate of 98.5% of our patients have an NGS test. Here the mutation testing is extremely good, and we see, focusing today on MET14 skipping mutation, 3.3%. Why do we have such a huge, independent of the tumor staging, good NGS tests? If tissue is not available, what we have in about 85 till 90%, we do liquid biopsy, NGS, to exclude mutations. For sure, when the patient has a very small tumor, the liquid biopsy we don't perform, because normally we don't find here something in this situation. So the treatment nowadays is that we can offer chemotherapy, immunotherapy, targeted therapy, also bispecific monoclonal antibodies and antibody drug conjugates. And based on the finding in the NGS, based on the immunohistochemical staining, we try to establish the right treatment in this situation. What about targeted therapies that are available? And here's just a summary from our publication, where you can see in different situations, different drugs are available. Focus today MET. For MET14 skipping mutation, we have availability for tepotinib and carbatinib. In this indication, for the MET amplification, in the moment, we just have access to tepotinib in this situation. Also, for EGFR mutated patients, we could use amivantamab in this indication, but the data from the INSIGHT 2 study are extremely motivating, and I would not go here for the for amivantamab plus chemo. I would here prefer OSI plus tepotinib. Here is the summary how we treat in our center in the moment. Patients stage 4 driver mutation are receiving mainly the targeted therapy. If there is no driver, the patients are receiving upfront immunotherapy plus minus chemotherapy. The only population that is KRAS G12C mutated, we can offer sotorasib, and since some weeks also adagrasib in this indication. Here is the only targeted therapy group where we would use the NGS test in the second line setting, but we also have studies in first line in this setting, so it is helpful to have the result upfront. And now I will focus on the MET14 skipping mutation patients. This patient group is normally older, history of smoking, female and male patients. PD-L1 expression is similar to these patients that we have normally. When we don't treat these patients without a MET inhibitor, the patient's outcome, like you can see here, in comparison to not MET14 skipping mutation patients, the outcome is clearly worse and really heavily worse. So it's so important that we really try to treat these patients upfront in this indication. Here's also what I told you. Please test patients when we treat patients with MET14 skipping mutation with immunotherapy. Median PFS is extremely poor. Also, the OS just on chemotherapy treated patients is also extremely poor. When you treat these patients with a MET inhibitor, the outcome is clearly better. So it's so important to have the result with MET14 skipping mutation already initially. We have data also in the sequential strategy, but then the problem is a lot of these patients, when they don't get the tepotinib upfront, we lose these patients when they get immunotherapy or immunotherapy plus chemotherapy. We lose these patients because these patients are perhaps missing the treatment in this indication. Just to get an insight about how we do it and what is the option for our patient. This is a 55-year-old patient, good performance status, and the patient came from our neurological department having a stroke. And here you see in the whole 5 different brain metastases, here with a little bit of perifocal edema and relatively small lesions in the lungs. And our neurologists know that we can have treatments that are working also in the brain. So automatically these patients are not sent to the radiotherapist. They wait that we do the bronchoscopy, get the NGS, and then decide if we have a treatment that is also working in the brain. Why do we do that? Because when you already start with cortisone, the patient will improve neurologically, but then we can start relatively early with the targeted therapy. And what we found is PD-L1 staining 70%, but we know when we get the result after 2 or 3 days, it's not useful to start immunotherapy in this patient group like I showed you before. So we always have to wait for the targeted therapy option. And here we started in this N2 M1C1 situation with tepotinib in the first line. And you see 6 weeks after the first follow-up, a complete remission without radiotherapy in this patient. And you see here the lesion with the perifocal edema and the complete remission in the brain. And this is not a unique patient. This is something we regularly see in these patients with MET14 skipping mutation. This was a neurological symptomatic patient. Normally, we don't have data for these patients. And you see here a very good remission. And this remission is still lasting. For now 2 years, the patient is on depot. What we see in these patients where we have this good complete remission, we know the outcome of this patient is excellent, and this is really extremely motivating. Why do I talk about MET14 skipping mutation, and why is it so important to understand which part of the MET alteration is there? Because in the past, I sometimes got the information from a colleague, the patient has a MET alteration, but there are so many differences. We can have a MET mutation, we can have an amplification. These are the parts that we discussed today, but we can also have a MET overexpression that is, for example, for different ADCs important. But in the moment examined in the best way is MET14 skipping mutation and amplification. And now I will focus on the MET14 skipping mutation. The more MET14 skipping mutation in our center makes about 3 till 4% out. 3 till 4%. There can be also a coexisting MET amplification, but this doesn't matter and has no impact on the decision. Here we can also find in the amplification in generally in non-small cell lung cancer for the EGFR mutated patients, like we saw before from Niti Karishna Raitsada, that this is also important and has an impact on the decision. The overexpression still has no clear impact. We have which are the MET alterations that we can treat. Now I'm focusing on the MET14 skipping mutations. Here's a bunch of different drugs examined, available, but at the end, the strongest compounds here are tepotinib, capmatinib, and savolitinib. And for us, clearly with the one daily administration and the best data in this indication is tepotinib, clearly with 2 pills only in the morning is extremely easy to administer. On the other hand, we have also MET-active monoclonal antibodies, and here the best known is amivantamab in this situation, and also in our center, Teliso-V is also an ADC that can be used in this indication, and also amivantamab in this EGFR mutated group patients. Here's an overview of the different drugs and the best outcome. Here you see on the bottom on the median progression. You see here the median progression-free survival, and here you see the overall survival. And when we compare all these different drugs, therefore I said tepotinib is the best examined drug in this situation, and the bigger the ball is, the more data are available. And you see in comparison, even a head-to-head comparison is not allowed, but we just try to summarize in this graph. The data is showing that tepotinib does for our patients the best job in terms of PFS in OS. Even it's not a head-to-head comparison, but we get an impression in this situation. We have different trials, tepotinib with the VISION study, capmatinib with the geometry study. Even I'm second author of the geometry study. I'm not using capmatinib with the twice daily administration and the stronger data for tepotinib. It's also a good option, but for me in the moment, it's still the tepotinib administration. Which other drugs are also here available based on the time? I will not to focus too much. I only wanted to share with you mainly that there are other data, phase 2 trials, but it's not so necessary. When we now look at the overall remission rates, please focus here also on the strongest data of capmatinib, tepotinib, and savolitinib, which have a registration or are in early development. And you can see here in terms of PFS, here you can see the overall remission rate. Here you see ORR. The best drug here is for sure in treatment naive patients in the biggest group with 111 patients, for sure tepotinib in this indication, including the PFS of 29.7, the overall survival data with 29.7 months, and the best PFS with 15.9 months. So for me, when I just see this graph, it's a must, for me at least, clearly that I prefer tepotinib in this indication, even other drugs available. The vision study is here shown. The vision study included patients in the advanced setting. No other treatment in terms of MET blockade was allowed, and patients had to have at least one treatment, two prior tumor treatment lines. So chemotherapy and immunotherapy was in the majority of the patients already administered. There were different cohorts that were then summarized, and in the treatment naive group is 164 patients and previously treated 149 patients. And you see here in first line tepotinib patients and second line data that the group were comparable. More data for the first line data, and it's not a head-to-head comparison, it's a mono-arm study in this situation. And you can see here for the patients with a treatment naive 15.9 months, like in our patient 15.9 months is now doing more than 24 months in this situation. The sooner the better, and I think this is something you would never reach out with chemo IO in these patients. Also, the overall survival is reaching the 3 years, and also the duration of response. When somebody is responding, these patients are responding really, really long. So when I see the data, even I have first, second, or third line data, the first line data are extremely positive. And for me, based on this data, first line is clearly recommended. The second line data, when you already started the treatment or is progressing, and you have just the availability based on the label in the second line, then the second line is also showing a clear efficacy. But when I compare it to the first line, this is for sure the better way to start it in first line. In Austria, we don't have the access to the first line officially. It's not labeled, but here we have to do it that the patient is getting 2 packages in this situation, or collect tepotinib from other patients, and then when it's showing a remission after 1 month, the patient is paid by the insurance when it's showing an efficacy. So we try always to show you the first line data clearly against the second line, where you see a better efficacy. The side effects of the different drugs, tepotinib, capmatinib, and savolitinib, are quite comparable. We always see the peripheral edema, we see always the liver enzyme elevations, and we see some nausea, gastrointestinal side effects. I would say the gastrointestinal side effects with nausea, diarrhea, and liver enzyme elevation is relatively easy to manage. The peripheral edema can be sometimes tricky. And initially, when I saw it, I was a little bit with 11.2 months grade 3. This can be really leading to an hospital administration or something like that, because the edema can be sometimes really tricky. The rationale behind what is really happening and how can we really treat this edema is unclear. So there is some theories, but not a clear reason. So normally we recommend our patients to use stockings already before the patient is trying to elevate the hands or the arms when it's possible, to avoid this edema. Normally anti-diuretic treatments are not working in this indication. So a lot of fellows are giving them treatments when the patient is not showing us in our hospital. So only when the patient has some other diseases already before, cardiac problems already initially, and this can help. But normally antidiuretics do not work in this situation. So it's good to monitor regularly these patients, especially in the beginning, in the first 3 months. They're happening more often. And important to know that this management with dose reduction and interruption are most of the time the best way. Normally, when it's happening and it's really something heavy for the patient, we restart tepotinib after the pausing and improvement with 1 pill daily. Then normally it's relatively well managed. So here is the preventive measures, patients' education on edema prevention, working with multidisciplinary teams. Sometimes lymphatic massage can happen in this situation, and the use of diuretics like furosemide, from my personal experience, does not really help. Only if the patient has an indication already before, then it can be supportive in this situation. I showed you a case before about the intracranial activity. We know that tepotinib is very good working in the brain compared to capmatinib, savolitinib, or cabozantinib. You see the others are also working, but from the data we have, the strongest data for brain mets are also with tepotinib in this indication. At the end of this first talk, here's the resistance mechanisms are described, but I can summarize: when somebody is progressing on tepotinib, we don't have the chance to switch to another drug in this situation. I did it initially sometimes, that then I gave them chemo IO, and then I reinitiated another or the same MET inhibitor, but it was never really successful. Also here, some cases from our center. Patient that is 83 years old, had a lobectomy, and then progressed. And you see here a pleural effusion, ACOG2, typical MET14 skipping mutation, comorbidities like you can see diabetes, arterial hypertension, and COP2. And we started here in February 2024 with tepotinib, and you see the pleural effusion improved in this situation. Also, pleural effusion can happen on tepotinib, like you can have fluid in the legs, in the arms. You can have also pleural effusion sometimes, but normally with stopping and reinducing, it's relatively good. Here we had a malign pleural effusion, and with tepotinib, it worked quite well, and the patient is still ongoing. Here, no relevant side effects happened in this patient. Here, this is a lady with a red right-sided huge tumor with pleural effusion that also showed, after initiating of tepotinib recently, half a year ago, a very good complete remission in the situation. And what we see from my personal experience, patients who have a complete remission are doing really extremely fine. Here are some cases, but I see the time is already a little bit progressing. I just wanted to show you a lot of patients. Patient here received chemo initially, progressed relatively soon, and then with tepotinib, a very good tumor control, and some cases with brain mets that I wanted to show you in this indication. So this is my summary of my first talk. Lung cancer treatment is not a one-size-fits-all. Each case is unique. We have to base our decision on NGS, PD-L1, comorbidities, and patient preferences. In MET14 skipping mutation, tepotinib is, my opinion, the best and strongest drug in this indication. And in the moment after tepotinib failure, the role of rebiopsy is unclear, and I would not recommend it. And thank you very much. And I hand over to my nice chair lady.
Thank you, Professor. Thanks a lot for that insightful presentation. You have really set the stage for further clinical discussion. Es war sehr informativ. Following this, we have a moderated clinical discussion. For that, our moderator for today is Dr. Ashish Singh. Just give me a moment to share my screen. Yes. So we have a moderated session now. Dr. Ashish Singh will be the moderator. He's the professor and head of the department at Christian Medical College, Vellore, the Department of Medical Oncology. And our panelists for today are Dr. Ullas Batra, Dr. Bivas Biswas, Dr. Akhil Kapoor, Dr. Alok Goel, and Dr. Hockmeyer. So I welcome our moderator for today, Dr. Ashish Singh, and our esteemed panelists. Dr. Ashish Singh, I would request you to please take the proceedings ahead for the moderated panel discussion. Over to you, sir.
Thank you, Dr. Shreyas. Thank you, Dr. Max. That was a fantastic presentation, and it was, you covered almost everything in terms of the science, and it's heartening to see that even though this is an uncommon situation, but we have made a great deal of progress. And we in India, have you ever been to India, sir, before?
No, unfortunately, no.
Okay. Okay. So
Time to come to you.
So even though if you look on the map, India is a big country, but having said that, at least in lung cancer space, I can say that from our experience has been really similar to what your experience has been in terms of timelines from the patients arriving to the diagnosis, to the molecular diagnosis and treatment initiation. And we are also very happy that Merck has made this drug available. We also have the Novartis drug capmatinib available. And to share our experience, so science you have covered so beautifully. So we would probably not get into that, but I would probably want to learn from experience of my friends and colleagues. And we're so happy to be joined by many of them. Even though India is a big country, we are a very small, close-knit community of medical oncologists, and at some point in time, we all have worked together, and we were colleagues, and we still continue to work together. So, if I can have the videos on, at least I would know. I can see Akhil, and Dr. Akhil is a friend and colleague at Varanasi. Dr. Alok, Dr. Alok, are you around?
Yeah.
Hi. So Dr. Alok works in Chandigarh, and Dr. Nandini. I don't see Dr. Nandini.
Dr. Nandini will not be joining us, sir.
Okay. So Akhil, it's me, Akhil, and Alok, and Dr. Bivas. So let me just begin with a patient of mine. Let me share the screen.
So Dr. Neeti would be there also in the panel.
Sure.
Just one note, Dr. Singh. Dr. Neeti will not be a part of the panel, sir.
No problem. If whoever I see on the panel, we will have a discussion. Otherwise, I have Dr. Max, and it will be a conversation with.
Sure, sir.
So I hope we can everyone can see the screen. So this is a real patient which we treated a couple of years ago, and so he's a 62-year-old gentleman, and surprisingly, so this slide was actually made some time ago, and I had an exact same presentation of another patient just last month. So these are two very smart middle-aged gentlemen who just retired, and they were going on with their daily lives, and their presentation was actually with difficulty in speaking. And another patient of mine, he was actually a lawyer, and then he was actually teaching a student, and then he couldn't actually remember which exact law we should refer to. So, and otherwise, no cough, no breathing difficulty, nothing. And based on this, so the local physician felt that this is probably a cerebrovascular accident, and the patient gets worked up, and on workup, on imaging, we actually see a space of occupying lesion. And you see here there is this lesion in the right superior frontal gyrus, and the same imaging actually did also show some abnormality in the pituitary stalk, and this with the suspicion that there possibly could be a second lesion over there. So of course with this there is the diagnosis is probably a metastasis, and then begins the search for the primary, and that a PET was done, and the PET shows a lesion which you can see on your screen. It's a pretty large lesion, a T3 lesion, with small lymph nodes involving even the contralateral mediastinal nodes, and thankfully there were no other visceral metastasis, no liver metastasis, no bone metastasis, and no other pulmonary metastasis. So our final diagnosis came after we did a CT guided biopsy from this lung mass, and this was reported to be a non-small cell carcinoma, possibly adenocarcinoma, which was positive for TTF1, negative for P40. Right. So if I can now kind of open the floor for discussion, I'm sorry, I'm on my iPad, but I can see Dr. Akhil. So Dr. Akhil, this is a very common situation. And in this situation, I mean, what would you do? I mean, patient has come now with a diagnosis of a lung cancer. What would you do in this situation?
So, sir, I presume tissue is available
Yes.
and we can go ahead with testing. Uh, NGS test should be ordered, and we try to get it. What we do at our center is to do cfDNA based EGFR at the baseline itself, because 40 to 45% of our patients are EGFR mutated, and also baseline EGFR is one of the prognostic factors which we take into account. So baseline EGFR along with NGS and PDL1, that is already being said. And since if the patient is having significant symptoms, which seems so, is I don't know about the exact symptoms. If the
So
patient
his symptom was only difficulty finding words. Otherwise, no raised intracranial tension, no seizures.
Okay, definitely. If there are no major symptoms, we can await NGS, which in our institute now takes 8 to 10 working days. NGS reports, which have in the last 3 years have the time has significantly reduced from 4 weeks to 3 weeks, then now 2 weeks, now 8 to 10 working days. So that helps. Any other?
So that's excellent. I mean, you're privileged to work in a center. Dr. Alok, NGS turnaround time at your center is approximately?
So we have just started doing our NGS. So our institute is 2 years old. We didn't have NGS. We have just started doing NGS, and to say 2 weeks at present. So we
Because
kept the bar at 2 weeks, and we are getting reports in 2 weeks. We will try to get it as early as possible.
Yeah. So in my center, it's about 2 to 3 weeks. We are also trying to improve our turnaround time. So let's just discuss what happens in this 3 weeks. So I mean, how would you all handle this patient during these 3 weeks? Suppose Dr. Akhil, your EGFR has come negative in the blood, and we have done ALK, and ALK has come negative on the IHC, and PDL1 say 40%. And because I've just wanted the audience to even kind of understand, because there's no one way of handling this, right? I'm sure there are many options. What would each one of us do?
Sir, actually, we have 7 trials in first line settings.
Okay.
So we
But
don't.
all that only after NGS comes. So now NGS has
Yes.
not come. Yeah, NGS
Yes,
has not
correct.
come. So what do? You just wait?
Yes, sir. We try to wait as much as
That's
possible, except if patient is performance status deteriorating, symptoms are
No,
increasing.
he's perfectly fine. So Dr. Max, in Austria, are your patients willing to wait for 3 weeks?
This was a long discussion with our pathologists, and I know 5 years ago we had the same problems to wait 3 weeks. Nowadays, we are waiting 5 working days,
Right.
till the worst 7 working days. And here, this is always, even the patient is perhaps putting a lot of pressure. We always wait this time.
Right. So 2 out of my panelists, rest of anybody else who would not wait? Dr. Bivas, Dr. Niti, Dr. Alok, yes.
So we always counsel the patient. 90% of the patient do agree that they will not start treatment, but sometimes some patients are very adamant, very apprehensive of not starting a treatment.
Alok, you're in Punjab, so I think you have the most aggressive patients.
So some patients are very apprehensive, and despite explaining them, some are very apprehensive that not starting treatment will. So yes, some patient we do have to start treatment, but we try to.
Are you tempted to say, okay, let's send him to neurosurgery, let's do a metastatectomy, or let's do SBRT while we wait for NGS?
Not really in such type of patient which is asymptomatic. No.
Right.
No.
Right. Because the plasma EGFR is negative, ALK is negative.
That is what it says.
So why not give CNS directed therapy now itself?
Can I come in, Ashish?
Hi, sir. Welcome, sir. I didn't notice you were also here.
I have become an unnoticeable person now.
Because I'm on my iPad, I can't see everybody. Only the person speaking. Yes, sir. Tell sir.
So I think I would agree with your point of view. If the EGFR ALK is negative and there is a single lesion in the brain, in the time that I want to get the NGS report, I would actually want to get the brain issue ascertained, because, so how much will ROS come? 1%. How many people will get entrectinib or repotrectinib? Very few. How much will MET come positive? 2%. Remaining, you will ultimately have to address the brain lesion. So I told them, actually, it's a blessing in disguise. Let's address the brain lesion during this waiting time of 2 weeks, and then go ahead with that.
True. So that's an important point. So because you're hoping for a alteration for which we may not have a good CNS active agent. And also, Dr. Max, in Austria, I mean, your insurance will not approve without a molecular report. But what about Dr. Bivas? What about empiric EGFR TKI while we are awaiting NGS? Because our incidence may not be just 20-30%. Our incidence in some parts is 40%. Okay, Dr. Bivas is not there. Dr. Alok, would you start him on some EGFR TKI while you're awaiting? Or why not chemotherapy? No one is saying chemotherapy.
So that is what I said, some patients who are very apprehensive, and that time I start chemotherapy in those patients, but I don't start empirical EGFR TKI unless I feel the patient is very frail and had a very bad PS and will not tolerate any therapy. Then very few patients, yes, but not a routine nowadays. It used to be few years back, but not now.
Right. So this was actually in 2022. So we did offer SBRT while we were waiting NGS. Mind you, those days NGS turnaround time was longer. And we confirmed EGFR and ALK, and we actually did start this patient on carbopem and pembro 4 cycles. So what if this patient would have come today? Dr. Akhil, would you, and if today, if you know that there is an exon 14 skipping mutation, your first line therapy will be?
Definitely not a doubt, sir. We have access to both the MET TKIs which are available. Till now, there was a phase 4 trial for capmatinib, which helped us a lot of patients.
So are you convinced with the data shown that your first line therapy should be a MET TKI and not anything else?
Correct, sir. I am convinced for MET exon 14 skipping mutation. I am fully convinced because of the activity of the drug, both intracranially and extracranially, and the data which we have. And also, we have already seen the data with MET, the benefit of immunotherapy is also slightly expected to be lesser.
So, Ullas sir, your publication, you have some experience with chemoimmunotherapy in this disease. Have you seen any long-term responders on immunotherapy?
Yeah,
what about the high PDL ones?
I mean, so high PDL1 is to me more reactive than anything else. I think tepotinib, any of both the MET TKIs have got a good intra and extracranial activity, plus the fact they're oral.
Yeah.
Patient doesn't have to come every 3 weeks. Reasonably well tolerable. I see no reason right now with the, and cost is also, if cost is a concern or some people to get reimbursement because of in IV therapies, then I might just put them across. Else, I think if this patient comes to me today, I will still stick on while I wait for the NGS report. I might just give SRS and then put the patient on TKI. But if I have the report of TKI in front of me, MET exon 14, if the patient is asymptomatic for the brain, I will not consider for brain radiation also. I will put them onto TKIs and then reassess in 2 to 3 months' time.
Yeah. So another question I wanted to ask you, sir, because you have a good lab and nowadays we're all moving towards liquid. Suppose if this patient on day 1 with this imaging finding, we would have sent the liquid and the liquid would have not picked any mutation. Are you confident about, will you make all your decisions just based on the negative liquid report? What about the concordance?
So
assume that this patient has a tissue MET exon skipping mutation. In what proportion will the liquid miss this?
30%, I guess. 30 to 35%, 60%, 70% is the concordance rate. So, what happens, Ashish, is the way I look at it, for me, tissue is the gold standard. If somebody cannot get the tissue after 2 attempts, I go for liquid. Now, if it's a non-smoker, I will actually go for a 3rd time tissue biopsy once again. If it's a smoker, tissue has not really come out, good smoker, and then liquid is not picking out anything, PD-L1 high, I will reluctantly go with liquid biopsy. But for me, tissue biopsy still is the main thing. In a non-smoker, every attempt should be made to get both tissue and liquid.
Right. Dr. Max, I'll probably come to you now. You've been investigator in a lot of these trials, especially vision and all that, where liquid was an acceptable method of screening. Your experience, like liquid missing and then the mutation being found on tumor later on?
So generally, normally when there's tissue, like in your case, I think I never missed tissue here, but if it happens, we go for liquid biopsy. But nevertheless, the liquid biopsy with the high sensitive methods, it works, but with the lower methods like COBAS or when you just do single gene testing in liquid biopsy, it does not work at all. So we need a broad panel NGS liquid biopsy, and this costs, at least in our country, 2,500 euros. It's possible,
I
but
think
I have to arrange it.
so. We all agree with this experience. I'm sure Dr. Ulas would have missed so many these skipping mutations on the 12 gene coupons. What do you say, Dr. Ulas?
I don't send 12 gene coupon in. Yes.
Yeah, so he made us an important point. So if your liquid has to be a good liquid biopsy, not just any liquid biopsy. Okay, so now let's just move on. So in this situation, okay, so we start tepotinib. Now, are we convinced that when we give tepotinib, we don't have to do any CNS directed therapy? Dr. Alok, would you also do SBRT if you have not done already, or you're okay with tepotinib? Intracranial efficacy of the drug. Are you convinced with what the data we have?
So if you look at the data is convincing. So that intracranial activity and intracranial response rates are in more than half of the patients.
Right.
So yes, I wait. matlab, I will wait until unless we see the responses are very fast. Also, we see responses within 6 to 8 weeks. Also, so both the response rate as well as duration of response is very quick. So most of the patients do respond, and I will not offer them SRS upfront if I have a report of metaxon and I'm starting them on a appropriate TPI.
Right. And as Dr. Max said, that 90% of patients would have some shrinkage. If you do resist, maybe 40-50% PR due to resist. Dr. Bivas, if you're there, okay, Dr. Bivas is not there. Maybe I'll come back to Dr. Akhil. Dr. Akhil, with these drugs which makes the tumor shrink so well, and especially in oligometastatic situation like this, what do you do at this point in time when the brain has regressed and the lung has regressed? Are you tempted to offer some local treatment, or you wait for progression?
Most of the times, sir, we continue with systemic therapy alone. Giving some local treatment, we are not sure that whether it is going to help in the long term. It is oligoprogressive where we want to add local treatment, but in such areas, I'm not very convinced about utilization of these treatment.
Dr. Max, in Austria, will you involve your radiation colleagues at this point, or you will not?
Normally, we have very good remission rates, like I showed you with the botinib. Normally, and also in the case I showed you, I would not go for radiotherapy and I would not do a local therapy. Only we don't see a remission initially. So when the patient has just stable disease or is not responding, then we use the local therapy.
Right. So that's very well said. I think that's what we should do. And the another question I had was, do we follow similar rules across different driver mutation? Dr. Ulas, I'll come back to you. What do we follow the same principles, whether it's a EGFR or ALK or MET, or we have different rules for a BRAF and different rules for a ALK? Especially when we have to select, because when we see our radiation colleagues, they'll say oligometastatic disease must be. I mean, we should attempt a curative attempt. Dr. Ulas, are you there?
Okay, yeah, you're asking me. Okay, fine. So I think in oligometastatic disease, my general philosophy is local therapy will make a good disease better or a better disease best. It will not turn a bad disease into a best disease. So that's the first thing.
Okay.
What I do is, a good to better to best, it won't end up bad to better one. So what I normally do is if somebody has outlived their, let's say on MET TKI, somebody has been going in for 2 years, 2.5 years, then and only one side of disease remaining, then I might consider. But unless or until that time, I am not really convinced. I agree with Akhil that I would probably like to go ahead with my local treatment, which we do a lot of time when it's an oligo progressive,
Mm-hmm.
not in a oligopersistent really. Oligopersistent, my radiation oncology colleagues also tell, sir, what are we going to take it out? Are you going to stop your treatment? I said, no. What are you really going to increase? So I
But
think
then there are some data in EGFR space.
yes.
The radiation guys have published in the Red Journal that they're improving PFS, which of course they will because they're ablating the target lesion. But yeah, overall survival, we do not know.
Yeah.
Okay, so we move on. We don't have much time. So
You
toxicity.
take mine also. Met amplification is as such nothing. You please take mine.
No, no, sir.
Go
So
ahead.
the toxicity, edema, I mean, Dr. Alok, your experience with managing edema, I mean, not only with tepotinib, I think even with crizotinib, capmatinib, even there's one patient I had with entrectinib. Sometimes this can be a real problem. And I don't know, Lasix, as Dr. Max said, doesn't work probably.
Doesn't work.
What do we do? Do
So
we reduce the dose? Have you reduced the dose because of edema anytime, sir? Any of you?
So I've done it in entrectinib. I was recently a patient who had a very troublesome peripheral edema, and I have to reduce the dose. So yes, it is troublesome in around 5 to 10% of patient where we need to reduce dose. Experience is not that much. I had around 5-6 patients whom I have treated with tepotinib, not that high, but yes, it's a troublesome thing. Unless I will agree with Dr. Macmillan that it doesn't seem to work very well in these type of scenarios.
And thankfully, we have not seen so much of liver toxicity, but that is described.
Can I comment on that, Ashish?
Yes, sir.
So, Ashish, I think prevention is better than cure in pediatric edema. That's the most important thing. And nothing that you will do once the edema comes in, nothing that you will do, even reducing dose also doesn't really help in coming down. So I tell my patients to be physically active. I tell my patients to be reducing their salt intake as much as they can. And at the first sign, do a do a bi-weekly weight recording. At the first sign, if you reduce the dose, it might work. But if you wait for the disease to come up with a good palatal edema, it will not really come down. So reduce salt intake, good exercises, and is the way to go and catch them early.
Sure.
Yeah.
So thank you. So I think I will end here and I'll hand it over back to Dr. Shreyas. I think Dr. Max has a talk now, followed by panel, right?
Yes, sir. Yes.
So over to you.
Yes. Thank you, sir. Thank you for that wonderful panel discussion and with a lot of clinical insights. Thank you for sharing your real-world clinical experience as well. Before we move on to the MET amplification section, there is a question, and we'll take it up before we move on to the MET-amp section. The question is there any difference between the MET-X14 variations, the skipping variations, and the response of TKIs to those skipping variations?
Who wants to answer? Should I or should somebody else do?
Yes, Dr. Max, over to you.
I didn't want. So we looked up this in our registry and looked it up very carefully, and we didn't see it comparable with red or comparable with other. When you dig deeper in EGFR deletion 19, you always can do subtypizations, and we didn't see that there's a difference. We also didn't see a difference also based on the data that an amplification, so a co-alteration, really changes a lot. We didn't find till now TP53 in the combination with MET15 or other relevant commutations for MET14 skipping. So in the moment, I would not care which type of MET skipping subgroup is there.
Thank you, sir. Okay, so no further questions. Then let's move on to the next section of our today's scientific session. Now we'll understand nuances of the MET amplification pathway and the management of MET-amp. For that, I would again like to welcome Dr. Professor Hochmeyer for his session on the management of MET-amp. Over to you, Professor.
Thank you. Also, an important topic that we discuss, I think, in MET14 skipping mutation, the landscape is extremely easy. For MET amplification, the data load is still relatively limited, and we have to do it a little bit more individual. On the other hand, the best study here focusing on MET amplification is the INSIGHT 2 trial that I will show you with the MET amplification. but there are also further investigations coming with other compounds, but at the moment the situation is relatively clear. Also, what we don't know is when we compare now with Mariposa in this situation after EGFR mutation failure and you have a MET amplification, is it clearly better to add tepotinib to osimertinib, or should we use here chemo plus amivantamab? Why is it for the company? It's clear the company of J&J is looking to get all patients in and are not digging deeper in this context because they want to have all patients. On the other hand, I say the smarter treatment with tepotinib is a very good reason, and we could also use later depo after depo osi also amivantamab plus chemotherapy, although I know this is just my thought behind that. It's also for insertion 20, when you use a TKI upfront and then you use AMI, it's still working. But when you use amivantamab, so there I think the logistical or the how you block the MET receptor is different when you use AMI or depo, and depo plus OSI is still the better tolerated drug. So when I have the chance to use depo plus OSI, I would go for this strategy, but I have actually no data to support that in this situation. Here's my presentation that I prepared. It will be a little bit faster because we are a little bit behind the schedule. So I will skip. I will not go too deep into this topic in some cases. Here, MET amplification is something we can measure relatively easy. We have here, we know when it's happening, the tumor is growing aggressive, and it's an important target that we can measure and treat. In generally, MET amplification is found in 1 till 5% of the non-small cell lung cancer patients, but we find it especially in the osimertinib resistance much more often. This is also the idea to add then to osimertinib amivantamab after amivantamab plus chemo based on the Mariposa 2 trial. Unfortunately, we have not tested these patients, that these are not data that patients with MET alteration did better. With the INSIGHT study, we have this data. What we know is that patients, when they get the treatment, when they have a MET amplification, the normal treatment with immunotherapy or systemic treatment is not working as good as the MET inhibitors. And this is the same for MET 14 skipping mutation or other MET alterations. So when you try to get here a MET inhibitor on board with MET amplification, it makes sense. How should we test MET amplification? The better way in the EGFR mutated patients is better to do tissue biopsy, but we can also do it with liquid biopsy, and it can be found, but the frequency of finding the MET amplification in liquid biopsy is higher in tissue in comparison to liquid biopsy. But for sure, the liquid biopsy is the easier way, perhaps sometimes in a little bit more expensive way, but it's for the patient the more appropriate way. And you have to have a good pathologist who can really do it, because when like I told you initially 10 years ago with our older pathologist, we just got to report MET alteration positive, but which type of MET alteration is extremely important in this setting. Which data do we have in this data set? Here we have from the VISION cohort data from advanced non-small cell lung cancer, high-level MET amplifications without MET 14 skipping mutation, so really only MET amplificated patients who received here in this situation tepotinib once daily. And here you see the patient group first line, second line, third line. So here not a lot of patients, and it's also hard to find this patient group, but it's just informative that in these MET amplificated patients, we really see, especially in first line, relatively good data. Unfortunately, we don't have a label for this indication for sure, but it also shows us how good in MET amplificated patients this drug works. And for sure, also always the same, the earlier you treat a target, the better in this situation. Then we have, I can leave that a little bit behind. For sure, the most important indication, focusing on MET amplification, is the situation with EGFR mutated patients. Here is some data that here I acquired from efficacy from real-world data, just in the beginning, where we see that this drug works, especially in patients where EGFR mutated patients received after failure of the EGFR mutation, having an EGFR amplification or alteration, that this drug works really nice in this situation in combination with EGFR mutation. And this led to this INSIGHT 2 trial. This INSIGHT 2 trial is a patient group where patient received first-line osimertinib and then had a MET amplification tested with FISH or liquid biopsy. What we always have to check, the gene copy number, and here it was selected by above 5 or above liquid biopsy 2.3. So when you have this, then patients can be were allowed to join the trial, Depo plus OSI combination. There was also a Depo arm alone, but normally you have still the EGFR mutation and then plus the MET signal pathway. So it makes no sense. This is something we just learn always with trials, that you just use here Depo. You need the combination in this situation. And here the patient disposition, really a huge trial. It's not easy to find this data. We saw it from the Indian colleague before, that you had really also a lot of experience already in this topic. And you see here 130 patients, 128 were available and we could receive the combination typical thoughts here in this situation. And here really the very positive result for patients after osimertinib failure. The majority of the patients had a clear response. When the patients are responding, it lasts with a median duration of 8.5 months. And here you can see that it was also a very rapid response in this indication. Also very important endpoints, median PFS 5.6 months against and overall survival data 17.8 months. But 6 months, still a very good amount that we can reach, not with chemotherapy. With chemotherapy, we reach out for 4 point little bit. When we combine with Mariposa regimen, we're reaching out for 6 months. So even when amivantamab is included in the strategy. So from my side, these data are really convincing in this situation, and it's still just an oral drug in this indication. Also, we know that half of our patients with EGFR mutation have brain metastases. So the efficacy of tepotinib, I showed you already before, is working. And here also aligned by this trial that you can see also Depo plus OSI can lead then to a remission in this situation. There are no new signs of adverse events. Everybody of you have experience with osimertinib. When you combine OSI and tepotinib, you are getting the typical Depo side effects, but not synergistic more side effects in this situation. And only 3.1% needed a reduction of OSI in this situation. Reduction of Depo was needed in 20%. The population of this group is for sure different to our population that we normally have on MET14 skipping mutation. Like I showed you here, these patients are normally younger. No, I didn't show you. These patients are normally younger patients, and this patient group has not so many comorbidities. So normally the efficacy is still there, and also the tolerability is for sure better in this situation. Here is the summary. and really motivating data. And it's something we do. For sure, it's not so often that we can do it, but it's something we can do. And here, one of our patients that had was running on osimertinib, relatively short, had then a MET amplification in the liquid biopsy without rebiopsy, and having then a very good response in this indication that lasted 10 months. And then we had to switch to chemotherapy in combination with amivantamab. And it also worked. So here in this situation, the patient was then chemotherapy free and helped also a lot. This is my summary, especially for the patient with MET amplification happening in this situation on progression in EGFR mutated patients. I think this is a very good option. Further data will come in other MET amplificated patients, but here I see the best chance for a patient. And I hand over to the great chairman who did already a great job. Thank you.
Thank you, Professor. Thank you for that talk. I think it's an area of increasing relevance, the MET amplification. Now to delve deep and go into the real world implications of the biomarker driven pathogenesis, I would request Dr. Ullas Batra sir, who is our moderator for today, to please take over the session for the MET amplification. Just give me a moment. I'll just share Dr. Sir's introduction. Yes.
Okay.
So our moderator for today's session is Dr. Ullas Batra sir. He is the co-director of medical oncology and the chief of thoracic medical oncology at the Rajiv Gandhi Cancer Institute and Research Center, Delhi. Sir, I would request you to please take over the proceedings. I will stop sharing my screen.
Okay. Fantastic. I was actually thinking of, buying some time and finishing off early because it is 8:20 in the night and we all are hungry. I hope my slides are visible.
Yes, sir. They are
Okay.
visible.
So we have
Yes.
2 A's and 1 B, and we have Ashish, Akhil, Alok. So we have 3 A's. Tepotinib has got 3 A's today. 1 B, that is probably me, and Professor Maximilian. Okay, so we'll start with it. Ashish, I'll start with you. Is MET amplification a part of your panel? I mean, a de novo patient comes, the 12 gene panel or something. Would you ask for a MET amplification de novo?
No, sir, I have not seen it. Even though we do our NGS panel, MET amplification is uncommon, I would say. It's part of our panel, but I haven't seen very often in lung cancer.
It's a part of your panel as such.
The MET is part of our panel. Now, amplification on the report, I have seen more skipping mutation than amplification. Baseline.
Typically, MET amplification, generally, whatever panels I have been involved in is not a part of a routine panel. We, in fact, ask our people, they do a MET copy number again, and then they confirm by FISH. So typically, and the coupon scan that you were talking about, typically MET is not really a part of that. Let me go to Bivas. Bivas, MET amplification is a part of your de novo NGS panel?
Yes, sir. We're mostly doing this 52 gene panel, and it has MET amplification.
Fantastic. Akhil?
Yes, it's part of our panel, which we use uniformly.
And how frequently do you see that, Akhil, if I have to ask you, MET amplification?
First line, we see in some patients of EGFR as well. We were discussing a case in molecular tumor board yesterday itself. But yes, it doesn't change much of our decisions. But we keep on seeing it, though not very frequent, but we keep on seeing in the first line itself.
Okay. So how does the report come as, Akhil? I'll start with you only. When you have a MET amplification on that, how was the report come as? We have 2 ways in which this report is actually seen on this. Let me just put it across over here. This is here. So you have 2 reports. One is, this is by FISH, I guess. One is MET by CEP7 ratio. And what is MET GCN? So let's say your NGS report reports it as a MET amplification. What do you look at? Do you confirm by FISH? Do you do IHC? How do you really go about it?
Sir, if gene copy number, if the copy numbers are more than 10, we usually do not do FISH for confirmation.
Okay.
If it is between 4 to 7, sometimes we ask for FISH.
Okay.
But if it is 10 or above, we don't do it because we are
Don't
more
ask.
sure.
Confirm by FISH. You will absolutely okay with the copy gain number. Okay. Ashish? Copy number gain and fish, how do you do? And in fact, the latest trials, in fact, the Savannah, you're not supposed to say the Savannah word and the TV word over here in the Merck Symposium, but both of them are actually incorporating IHC now.
Yeah.
So how does it go with your center, Ashish?
Yes, so as I said, I don't have much experience upfront. I mean, we have tried in patients progressing in EGFR mutated patients. We have tried repeat biopsies and NGS. I mean, even though we do have our IHCs as well, but I think our pathologists also are probably not very well versed with what is exactly is amplification. So that this is a very gray area, I would say, currently.
So anybody utilizing a meta-HC in this
Anybody
situation?
using a meta? Nobody is using meta IHC at present now. But I think we were involved in the Savannah trial and the subsequent discussion. They were Ganga, they said you at least more than 90% cutoff if you can use, because IHC is easy. They wanted to do it like, ALK by IHC or at least a screening test. But I think we need to talk to our pathologists and get the clones from there and then go ahead with that. So also, there is a trial. I think there's also this thing, the numbers are so small that in a de novo thing, as Ashish was saying, you hardly see anything. And even with MET amplification of post osimertinib, it is hardly 7, 8%, 10%. So you don't really, numbers are not there for people to invest in that. Vivas, your thoughts on how do you do NGS? Do you do it by FISH, IHC?
So most, as I said, in initial panel, I have seen very rarely. It's very infrequent to have MET amplification. They report mostly as a MET amplification. Then we ask whether you have a copy number or not. Where we are doing mostly is the post TCAT, post osimertinib, and post lorlatinib. I have two patients who has a post lorlatinib, very high copy number 20, and in-house we are sending for fish also at the same time. Just rebiopsy. There's adenocarcinoma sent for fish because that is the most common resistant mechanism for most of the patients. So fish, yeah, as Dr. Akhil mentioned, if I have a copy number more than 10, then I am happy to go ahead with the copy number. And as you mentioned in Savannah, yes, they are using this IHC, 1 plus 2 plus 3 plus. But I think this is a special technique, special clone, not I think many of us don't know how to score that and how to report that and what is the concordance with copy number or the IHC.
I think Ashish is trying to fetch an article. If I know Ashish well, he now some article will come on
He will put in the chat box.
No, these guys are too good, man. Ashish and
Yeah,
Akhil. I mean, they're too smart and too fast with that. So I'm waiting for the article, Ashish. Tell me.
No, sir. I'm also hungry.
Okay, okay, fine. You're looking at the menu. Professor Maximilian, if you are there, I would like to, I mean, because, when I speak to my molecular scientists, they are not very happy with MET amplifications in the NGS. They always will want to confirm by FISH. Tell me, and tell me what happens in NGS and what happens in FISH and what is the right thing or what is the thing that you follow.
So generally, my colleague from the pathological department knows what I need to know. So it doesn't matter when she reports something what I don't understand.
Correct.
So I have to explain, this is the reason why I could use depot in this situation. This is the reason why we test, and please give me this information. So she's not giving me the information about immunohistochemical staining when it doesn't matter at all. So when then it's written down MET alteration, immunohistochemical high, I don't care. So she knows, then she writes down exactly the gene copy number, what I need in this situation. But to be also FISH is something I have to ask specifically in this indication. It lasts half an hour for the pathologists and they don't like it at all. I remember when Alt was there, they loved it because they didn't have anything to do, but now they are completely overworked and I don't get it in the moment. I only have to ask specifically here in this indication.
So correct me if I'm wrong. I did ask my molecular pathologist and she told me there are two ways to report a MET amplification on the fish. One is that you do a MET by 7 CEP7 ratio. It's almost similar to like what you do for HER2/neu. Like, HER2/neu we do less than 1.8 and then more than 4 and then it gets amplified. That is on the left side of your screen. And one is an absolute copy number gain, which can be more than 5 or more than 10. I think I would agree with Akhil when he said that more than 10, you don't need to confirm. But somehow I will talk to my molecular pathologist again. They do want to compare everything on MET amplification by NGS by FISH. They just want to be doubly sure. Maybe we are not experienced enough. So I really don't know the answer for that. Okay. Let's say, Ashish, I'll start with you. Tomorrow in the WhatsApp University, tomorrow we get a lot of time a patient has come, or de novo metastatic NECLC. De novo MET amplification is positive. The score is more than 12. What will you do?
No, so I would probably just ignore, sir. It's not an actionable alteration. Yeah, first,
Even sitting in a Merck symposium, you will not like to look at the huge number of 11 patients which were treated in this and this. You don't want to do. Fantastic, Ashish. That is why you are a sweetheart to be there in the panel. Speak your mind. I would also agree. Akhil?
Yes, sir. I completely agree. There is no supporting data and recommendations to utilize in the first line settings. Amplification is always for the second line and beyond.
Correct. Bivas, I think you will echo
Same.
what has been said.
Same,
Okay,
no doubt.
let me also ask you now. Let's say this patient whose MET amplification is positive is also PDL1 90%. A lot of people will want to give immunotherapy plus tepotinib or whatever. Thoughts? Ashish, I'm not letting you look at the menu.
no, so if PDL1 is positive, then that may be good news, provided I have done a good NGS and it has.
Right. So people want to give immunotherapy, pembro plus tepotinib.
No, that is not a good strategy. You either target the immune system or you target the MET pathway.
Just before the evening dinner, everybody is honest over there and on to the point. We had a trial by Novartis, which was short for toxicity. They had given capmatinib plus pembro, and it was stopped for futility because a lot of toxicities were there. So please, no IO chemo and capmatinib, no IO and capmatinib on that. So I think Professor Maximilian, would it be safe to say de novo MET amplification? Don't ignore. People will have a poor PS, I agree, but a poor PFS. But that doesn't call that you should include capmatinib or tepotinib in your armamentarium. Do you agree with that?
Absolutely. And I was also part in trials combining immunotherapy with any TKI. And it's sometimes not only from the PFS, not better, there's no betterness, but you can have horrible side effects. So from my side,
don't
no.
do. Thank you. So let's me go to Alok is there? Alok is not there, I guess. Okay.
I am there.
Oh, so then why are you not putting on your video? Come put on your video. Okay, Alok. So you have an EGFR patient. You have done a NGS, and EGFR is positive, and so is MET amplification more than 10. So EGFR L858R and MET amplification more than 10. क्या करोगे?
Osimertinib, sir.
Only osimertinib. Yes. You don't want to combine osimertinib plus tepotinib or osimertinib plus anything else or a Mariposa or a thing?
Not at present. The data is not so convincing. I will just go for
Okay.
osimertinib at present.
Fantastic. Bivas?
I'll be tempted to use Mariposa, sir. I don't have laser team now.
We are all not coming to the Merck symposium in the next one. I'm 100% sure on that. Ashish?
So I feel looking at those insight waterfall and response rates and all that, if the MET amplification is real and we manage to pick it up, there's nothing like an oral option. And sometimes I actually feel very tempted, instead of doing a repeat biopsy, NGS, waiting for it, why not just give 1 month of a MET TK and see whether the patient is getting better, especially if you're not in a hurry to jump and change the osimertinib.
Okay, Akhil?
Sir, what we do, we usually start with single agent osimertinib most of the time. And if we see a patient responding, we do not change anything. But sometimes we see patient is not responding, there will be tempted to add tepotinib in that situation. So early response assessments and follow-ups become crucial in this scenario.
This was a study which was a plenary actually at last year's WCLC, Akhil, when we were there. And when you won the awards and everything from there. And this has basically said EGFR with MET amplification. And MET amplification was seen, I think, in less than 3% of all the people. In fact, a very thought-provoking study. And what they basically said and what Ashish was saying was right. If you give only OC, it is 9.3. If you get OC plus SAVO, it is 19.6. So there is a case, but the numbers are too small, 23 and 21. But I am sure, I mean, I would probably, if you ask me, I'll go for either a combination approach, whether combination is with the TKI or whether combination is with the Mariposa or with the Flora2, I will leave it to somebody this thing. But MET amplification will say it's a bad disease, tempted to add something to it, something to osimertinib. So, do you all do biopsies post osimertinib? Bivas, I'll start with you. And in what percentage have you seen MET amplification?
Yes, sir. I do try to do biopsy whenever it's possible and applicable. Majority, I'd say 60-70% I do. And MET amplification, not much, though it's reported is one of the common resistance, but not much, maybe less than 10%.
Change your lab and send it to Ashish's and Akhil's lab. They get a lot of MET amplifications in that. Okay, Ashish, do you biopsy everyone?
We try to, sir, but like I feel we're moving more towards liquid biopsies.
Okay.
Because
You did get IDH1 mutation, Ashish. Did you give the patient something?
no, that's very expensive at the moment.
Okay. Okay. Akhil?
Yes, sir. We try to get something, either liquid or tissue or both, whatever is feasible. 50% patients end up going biopsy, repeat biopsy, but we try to send both actually in this scenario, post TKI setting.
Okay. So, Alok, I'll come to you and then to Professor Maximilian. Alok, do you do biopsy for everyone? Tissue, liquid? What is your experience been?
Yes, we try to convince them. Yes, but we are able to get it in around 60 to 70% of the patients.
And how many times have you seen a liquid amplification, MET this thing? MET amplification?
Not very commonly, sir. Most of my biopsies are solid only, liquid are less, and I have not seen many MET amplifications.
So we have done a 80 patient, I think on osimertinib, we have around, we will be coming up with a paper, 250 patients, 112 have progressed. We have done biopsies in 80. 14% of people have got MET amplification. 7 of or 8 of them have got more than a PFS of 8 to 9 months. In addition to MET, we have got a lot of BRAFs. We have got a lot of ALKs, 2-3 ALKs. We have got some 3-4 BRAF. We have got 1 NTRK. So I think I'm a big proponent of doing a biopsy post, and we've got a 6% people change of histology to small cell carcinoma also. So I think every effort should be made to do a biopsy and send an NGS, preferably tissue. If not, do a liquid NGS also. Professor Maximilian, what's been your experience with that?
So we're trying our best to get it, but as you know, sometimes you have a progression in the brain. Sometimes the patient has any reason why a rebiopsy is not possible. I would say 40% of our patients receive a biopsy. I was also part of the HATENA study that was published recently, and it was really hard to, even we have the trial and we did rebiopsies, and here from the fit patients, 50% had material that we could really use to get all measurements that we need. Even I'm coming from a pulmonary unit. So I think it's necessary. The Tepotinib is really a reason to get these patients on board. The rest, what should we do with the small cell lung cancer? What should we do when the switch is somewhere else? There's no data that we really can use it. So the Tepotinib is the only reason why I'm doing the rebiopsy.
Okay. Dr. Maximilian, you said very clearly that, you know, if you have a MET amplification, you would like to go for OC plus tepotinib. Can I ask Ashish last question to you before I leave you to the dinner, make you pay for the dinner? Between Mariposa, ABCP, and OC plus tepotinib, let's say somebody has got a MET amplification, Mariposa 2, AMI plus PEMCARB, ABCP is there, IMpower, and a OC plus TPO. How would you decide? Or you say, don't do biopsy, give Mariposa to everyone?
No, sir. So I mean, of course, how do I decide? So oral and IV is a major factor over there. Also, the volume of disease, site of disease, and how rapidly the resistant or clinical progression. That is also another thing, because sometimes patients are like this leptomeningeal and brain and all that. It's because the level of evidence is probably better with Mariposa because it's a larger, well-designed trial. We don't have randomized data with the oral TKIs. So therefore, in some situations, it would be Mariposa. But in a slow-growing progression, isolated oligoprogression, in that situation, I would probably, patients also would prefer an oral option.
Oral option. Bivas, your choice between Mariposa and Insight?
For high MET amplified, I think OC plus one of the MET inhibitors will be my choice. For rest, Mariposa. The question is why to do biopsy? Yes, to load small cell and to load the screening out the high MET amplified who have a better PFS with common TKI and both TKI.
Alok, if you are there. Okay, I'll go to you, Professor Maxwell, once again. But Mariposa also is a bispecific antibody against MET. So, except for the toxicity profile, the IV thing, and the cost, anything else to separate amongst the two, Insight versus the Mariposa 2 regimen?
There are two things. It's an oral drug, tepotinib, on the one hand available. Mariposa is still chemotherapy, and it's extremely expensive. In Austria, we pay 130,000 euros for each treatment for 1 year, and here Depo and OSI is half of the price. So just this is also something I have to get advice. Besides what the patient is for sure taking 2 pills instead of getting IV infusion. This is the reason. But still, AMI, from the phase 3 trials, when I have an official talk in the Congress, I have to say that this is a phase 3 approved trial, and I have to say it. But my feeling as a physician, based talk for my patients, I would not use it in this indication. First, Depo plus OSI.
Your heart goes for tepotinib, but your lips are sealed when you go into a Congress.
Yeah.
That's it. No, I think it's an oral option. The toxicity profile is good. I would not really find any reason that the patient should not really want, and you can delay chemotherapy. For me, that's a huge important thing. And I mean, and having used this combination, being a part of Savannah, COC, everything, I think OC plus MET TKI tepotinib is a very good option on that. So I think we'll just forget about that. And I think to me, MET amplification needs to be tested. We need to talk to our pathologist and learn from them that, the tricks and tips of MET amplification in NGS versus FISH, the reporting it. Maybe do it in all the patients. I'm very happy that everybody is doing, and I think something which I need to learn and tell my pathologist, because we are not doing it upfront. But we should be doing it upfront, even in a EGFR mutant patient. Definitely, if a patient has progressed on osimertinib or anything else, we should do at progression, do a biopsy, try to get a MET amplification. If something is positive, the drug should be used. Only request, 2 requests to Merck over here would be: one, as usual, India, reduce the cost. Second, have a registry of post osimertinib data and MET amplification wherever we have given. We can all pull in our data, and that will be a good publication, a real world publication, which can come from the group. I think I spoke to Harsh before. That's the only request. Otherwise, we are all sold on the science. The drug works. The rest is for the data to come into the public domain. Any other points, Ashish, Professor Maximilian, Bivas?
So I will like to ask, when will you use ABC?
Yes.
In what scenario?
When will you use ABCP? Ashish, are you a fan?
No. I mean, I'm just waiting to see the Harmony data and even SCMAP data, but not ABCP for EGFR mutation.
I mean, somebody really eats my brains a lot on that. I will use ABCP. Although, having said that, there are 2 patients on ABCP which have done well. We don't know. We don't know. There are a couple of patients who will do well on immunotherapy. I have one patient who has done extremely well. It's not a mouth-watering approach. I mean, that's what I'll say.
So if you have a repeat biopsy showing squamous or say small cell, then maybe, I mean, you can discuss immunotherapy.
Yeah, so what we do is we do a biopsy, we do stimulation for NGS, something comes up, treat that. In fact, we have had a HER2/neu also come positive. We have actually given Enhertu on that now. I will let you know in maybe 3 months later, 2 months later, what the response was. Do a biopsy, do an NGS, rule out small cell. If there is no actionable, I give them an option of NGS. I give them an option of chemo versus ABCP. I lower my voice when I talk about ABCP. and just fill it up कि ठीक है यार देख लो कर सकते हो तो, but not really a big fan. That's what I will tell you.
Okay, sir. Thank you.
Okay, so that was it. Thank you. Thank you, everybody, in spite of their busy schedules and dinner being kept waiting. Thank you, everyone, and hand it back to the organizers.
Thank you, sir. Thank you for that crisp panel discussion. I think there are a lot of key takeaways from the panel discussion. We would like to close it very soon, but before closing, I would like to just request our chairperson for today, Dr. Neeti Raizada ma'am, to give her concluding remarks. Ma'am, over to you, please.
It was an awesome discussion by everybody, I guess. Our international speaker was really good and cleared all our concepts. I think we have very clear concepts about exon skipping mutation and its variants. MET AMP space is obviously a space to watch. We need to know more about anti-MET ADCs as well. I think that application also we probably have to look forward to. So thanks to Professor Maximilian. Thanks so much, Ullas, Dr. Ashish, Dr. Akhil, Dr. Alok, and Dr. Bivas, and the entire Merck team. Thanks so much and good night.
Thank you,
It was
everyone.
a pleasure. Ciao, ciao. Have a good dinner. I go for lunch. Ciao.